transversus abdominis plane block, and more recently the quadratus lumborum. So technically trying to put, when you put the needle and local anesthetic at the point between the transversus abdominis and the quadratus lumborum, hoping to actually make the local anesthetic move a bit more posteriorly and hoping for a better spread of the local anesthetic. There's also descriptions of the PEX block. I'm not going to go into great detail, but this has been described particularly for breast surgery, as well as some form of thoracic surgery. More recently, the new kit on the block, this is erector spinal plane block. So technically, instead of going epidurally, the idea is actually to deposit local anesthetic on beneath the plane of the erector spinal plane block, so between the transverse process and the erector spinal plane. There have been quite a few studies to actually prove its efficacy. This was actually by Philip McCare and his Vietnamese team. So this was looking at actually open cardiac surgery, and they have actually shown that the morphine consumption is very much less when patients are given erector spinal plane block. This is technically where you put it. So basically between the transverse process and the erector spinal muscle. Again, and in the catheter continuous technique, this is where you put in the catheter. And of course, if you have a unilateral surgery, then you only need to put for one side. But if it's a midline surgery, the block has to be performed bilaterally. In Malaysia, we just published this last year as part of our SIG-RA recommendations for peripheral nerve blocks. With regards to ultrasound-guided vascular access, this was actually the first publication in 1986 by Akitomo Yone, a Japanese. So what they did was actually use this T-shaped probe and documented the real-time approach for IJV cannulation. And of course, with probably not so recent, ASA has published guidelines on this, and plus various other bodies. As far as TEE, this was actually the first publication in Lancet in 1980, probably because of the poor crop, it's not coming up. But the use of the ultrasonic endoscope, and subsequently, since 1980, TEE has become an important modality for monitoring in the cardiothoracic anesthesia realm. There's also been, apart from cardiothoracic surgery, there's also been description of the use of focused intraoperative transthoracic echo to monitor hemodynamics, as well as to guide in fluid therapy. Okay, so initially, it was only in 2011 that there was actually a first documentation of the use of lung ultrasound to confirm the diagnosis of, it was a two-case series. So to confirm the diagnosis of pneumothorax. This was published in Anesthesiology in 2011. So subsequently, there was an editorial in the same issue. So if I could read out the editorial, the paragraph at least. If TEE, vascular access, and regional anesthesia represent established mainstream applications of perioperative ultrasound, chest ultrasound, and other modalities have emerged more recently among anesthesiologists. So technically at this point, we are at 2011, we can see that now there are emerging modalities of the use of ultrasounds rather than the traditional TEE, vascular access, and regional anesthesia. So in the same year, there was actually a New England Journal publication on point-of-care application, point-of-care ultrasonography. So at this point in time, if you could define what is point-of-care ultrasound, point-of-care is basically image that is obtained immediately, so it's real-time. It is not an ultrasound where the patients are sent to the radiology suite, and the ultrasound is performed by the radiologist or radiographer. It is actually performed by the clinician, here, and it is real-time dynamic images. Another characteristics apart from clinician perform and real-time is actually focus, because there are only several tick boxes that we like to tick whenever clinicians perform point-of-care ultrasound. We are not performing ultrasound as a complete examination like how the radiologist or radiographer does. And if you could see this list in 2011, right on top, anesthesia. So there's only vascular access, regional anesthesia, intraoperative monitoring of fluid status and cardiac function, mainly referring to TEE. And there's a long list of other specialties. We're not going to go into detail because the talk is mainly for perioperative, and I just probably want to concentrate on anesthesiologists or anesthetists perform point-of-care ultrasound. Subsequently, it was in 2017, there were quite a few series. This was actually a series by RAPM, Regional Anesthesia Pain Medicine, in 2017. They started to publish various point-of-care ultrasound modalities for what they title as regional anesthesiologists and pain specialists. So what is all about? So with regards to the literature, before 2011 and onwards, the use of point-of-care ultrasound by critical care emergency medicine specialists is quite well established. This was actually a publication by Luca Neri, Enrico Storti, and Daniel Lichtenstein, the founding fathers of the WinFocus group, in 2007 in critical care med. And you could see that actually what they propose is that an ABCD approach from airway, breathing, circulation, which includes echocardiography, vascular access, following down abdominal sonography, soft tissue. And the disability is cranial ultrasound, which I will touch a bit, looking at the optic nerve sheath diameter, and then miscellaneous, for example, preventing missed life-threatening lesions and so on and so forth. So this is an ABCD approach. It has actually been used and well documented in other specialties. It was only anesthesia picking it up probably in the last 8 to 9 years. There have been a lot of acronyms. This is one called Foresight, Focus, Perioperative Risk Evaluation, Sonography involving gastroabdominal, hemodynamic, and transthoracic ultrasound. It's quite a mouthful, but this is what you can do with ultrasound, as what the authors of this approach proposed, from ICP monitoring with the optic nerve sheath diameter, endotracheal tube placement, lung ultrasound, looking at evaluation to diagnose pneumothorax, effusion, and so on. Looking at the fast examination, focused abdominal sonography for trauma for evaluating free fluid, vascular access, hemodynamics, which include IBC examination as well as cardiac evaluation. I'm going to elaborate a bit on each of these modalities. Okay, this is actually a Canadian Journal of Anesthesiology publication 28 on the point of care ultrasound examination of the upper airway. And you could see that in the indications, it is listed as cricothyroid, identification of the cricothyroid membrane for the pre-anesthetic airway evaluation, tube ETT placement, as well as evaluation of the trachea and vocal cords. There have been other studies. This is actually from our Malaysian colleagues, Adi Osman and Kok Ming Sam, published this review 2016, role of upper airway ultrasound in airway management. There's been quite a number other of review articles published on the role of airway ultrasound, which I will probably not touch on. So just to kind of give you a teaser, again, the whole idea of the talk is it's going to be very difficult to cover everything in detail. But I was hoping that if you could, after listening to this, you could walk away with, if you're not practicing it, to probably have an interest to adopt point of care ultrasound. So you could see that in this is an actually image, a still image, but this is actually an image, the middle video of a tracheal intubation, and this is an image of an esophageal intubation. So, one may ask, if we have entitled CO2 and, the advent of video laryngoscopy, this may not be necessary. Well, it's true, but this can also be used as a rescue modality if, the entitled CO2 is giving some problems, or if you have issues with actually visualizing the vocal cords when you're intubating. The structures can actually be visualized. Okay, this is actually a real-time needle tracheostomy. You can see this needle is passing through, and this is in the long axis, and this is the short axis. So with ultrasound, you could actually confirm the structures. I believe probably in a patient who's very lean, that's probably not necessary. For those patients who are a bit probably overweight and obese, this may be quite helpful, particularly if you can't feel the structures. When you put the ultrasound in the midline, if it's really midline, this is what you're going to see. You'll be seeing actually this hyperechoic line, which is the air mucosal interface, and you will see these hypoechoic structures, which is actually the cartilages. Here, the one right in the middle on top usually is the cricoid cartilage and thyroid cartilage, and this is the cricothyroid membrane connecting the two cartilages. This happened a week or two ago, where we had a difficult tracheostomy. My ENT, this was a formal tracheostomy by the ENT, but what the surgeon was having difficulty in actually palpating, because the patient was actually quite obese, the structures, and I offered to help by actually documenting and confirming the structures. So this point where the surgeon is actually pointing is actually the cricoid cartilage, and this slope downwards on the curse. What my curse is showing is actually the cricothyroid membrane. So even though the surgeon should have probably been best equipped with the skills, but if they're not, then I believe as part of a good teamwork, the anesthetist should also be able to assist the surgeon in this particular instance. So there have been quite a few studies looking at how airway ultrasound can be used to predict a difficult airway. So I'm just going to probably just skim through because it's probably going to be quite lengthy if I cover it in great detail. So this is technically, if you put the ultrasound and you look for the hyoid bone, if you cannot visualize the hyoid bone, it predicts actually a relatively low sensitivity of 70%, but very specific 97% of cornea Lehen of more than 2 or more. So it's just to show that if there's a lot of tracheal fat, then definitely you will be dealing with a possible difficult airway. Again, ultrasound of the tongue, and if it's thicker than more than 6.1, is it an independent predictor for difficult intubation? There have been other published measurements or modality measurements with regards to predicting difficult airway. So from using the tongue base to skin, anterior and soft tissue of the neck, and so on and so forth. With regards to prendial status estimation, or I would say confirmation of prendial status with ultrasound. So this was actually a review article by the Toronto group. So we can actually use ultrasound by looking at the antrum. So this is actually a small antrum. This is an antrum filled with fluid, and this is an antrum filled with solid. There have been actually on the actual gastric volume. I won't go into great detail, but in my practice, if I have a patient who has a dubious history of fasting, I would probably perform this, and I would decide whether I'm happy to do laryngeal mask airway anesthesia, or I would, if I have any concerns with regards to the prandial status. If I see a larger entrance